Perfect. Hello, everybody. So welcome again to the seminar series for Machine Learning for Health. Today, we are very delighted to have Dr. Collin Stultz from MIT joining us. He is the Nina T. and Robert H. Rubin Professor in Medical Engineering and Science, a Professor of Electrical Engineering and Computer Science, co-director of the Harvard MIT Program in Health Sciences and Technology, and a member of the Research Laboratory of Electronics, and an associate member of the Computer Science and AI Lab, all at MIT. He's also a practicing cardiologist at MGH, and his scientific contributions include computational chemistry, biophysics, machine learning for cardiovascular risk stratification as well. And currently, the research in his group is focused on development of machine learning tools to guide clinical decision making. Today, he will talk to us about self-supervised learning for patient phenotyping and forecasting adverse events. Thank you.
Great. Thank you, Danielle and Manaz, for asking me to give this talk. It's always great to see you guys, and Sam, good to see you. And a shout out to Tara, who I see on the line as well. So I'm gonna try to give you somewhat of a schizophrenic talk today on self-supervised learning for patient phenotyping and forecasting adverse events. And it's a little bit of a bait and switch because some of this will be about self-supervised learning, but some of it will be about early fusion, late fusion, and a variety of topics that I think that are on the horizon. So just as a background, the work that's gone on in my group has spanned a panoply of different categories. So we started out, I hope you can see my mouse. Yeah, so we started out looking at problems centered around very small length scales, angstroms, nanometers, and so forth. We looked at collagen, protein folding, all with the use of computational models and how that influenced disease, and did a lot of work looking at folding landscapes and intrinsically disordered proteins. And within the last couple of decades, the last 20 years, I'd say, our work has been mainly in looking at phenomena on the level of meters, things that you can see with the naked eye. And this work sort of bridges my clinical interests both in cardiology at Mass General and a long desire by myself and those who I'm privileged to work with to impact the care of those who are ill. So I usually like to begin these discussions with setting the ground in terms of what healthcare looks like in 2025. So from time immemorial, healthcare has involved two participants. There's a patient and a healthcare provider. The patient generates information which the healthcare provider has to process and use these data to make decisions. And those decisions are what medications and procedures will make the patient either live longer or not feel pain or discomfort. And this is true irrespective of the field of medicine that one is interested in, disease that one is interested in looking at. What makes it different now is especially in industrialized settings, or the number of signals that the healthcare provider brings to bear to solve this problem. So I have a variety of different signals, a variety of different resolutions, and a variety of different complexities. So we have things that are structured, lists of numbers, and word and other things that within electronic health record, and unstructured data being words that appear in clinical notes. We have the electrocardiogram, the signal that has a sampling rate on the order of several lab values, MRI scans, ultrasound studies, CT scans, all that the clinician can use. And so the issue is, how can we model patient data given this complexity and given the fact that these modalities have different levels of information content and different resolutions? So it brings us to multimodal modeling. So we have a variety of different data inputs. They all look very different from one another. How would one approach this for looking at a particular task of interest? Well, the most straightforward thing is, if you've got a single modality, you can focus on that. You can build an encoder, something that translates this complex image into something that typically is of lower dimensionality that you can use to put into a program to accomplish some specified task. Now, the issue is, what do you do when you have many of them? And they're all very different. The electronic health record, ECG, labs, and so forth. You can make separate encoders and you can train them all independently for a specific task, and then you can combine that information after the fact to get your final prediction. This is typically called late fusion because you're not directly combining the data inputs per se, but you're combining the interpretation of the processed inputs that all for each train towards a specific task to get your final prediction. And you can imagine voting and different mechanisms to combine this information to make your final answer. The other way is early fusion. So I have these data, I have their representations, and I put all of these representations into some large complex model to accomplish some task. And typically, when I train this model, all of the information back propagates back through the encoders. So the information within the encoders and the embeddings that are learned necessarily include some information about the relationships within the data that one is using for the task of interest. Now, so just to compare and contrast these very, very quickly, late fusion enables different model types and architectures that can be readily combined. It's relatively straightforward to implement, but it does not directly leverage the information across modalities. By contrast, early fusion, you can exploit shared information between modalities, in particular, as I've already described. But they're more challenging to train because the models tend to be more complex, and there's a dimensionality problem. You have multiple modalities, each of them with some relatively high dimensional vector representation, and all of these have to go into memory, be stored, and you have to do something interesting with them. So I'm going to talk a little bit first, in the first part of my talk, focus on early fusion, some of the results that we've had with early fusion, and what the types of problems that we can tackle with this. And then I'll generalize later, talk more about self-supervised learning. So in a multimodal setting, with early fusion, I'm going to talk about two data streams that we use, and it's the ECG and electronic health record. And a lot of the work that I'm talking about here was done by a talented student who's a former member of my group, Payal Chandak, who's now working with Zach Cohen. So this is about forecasting left ventricular systolic function in patients with heart failure. Now, for people who may not be akin to this, heart failure is a disorder where the heart is not able to pump out enough blood to meet the metabolic demands of the body. It affects millions of individuals in the United States and worldwide. Very high mortality and morbidity associated with this. In some cohorts, the 5-year mortality rate has been as high as 40 or 50%, which is worse than many cancers. Identifying which patients with heart failure will have a worse prognosis in time is an unmet need. And the left ventricular ejection fraction is highly correlated with with future risk of mortality and also future morbidity. So our goal in this study is to use a simple signal, the ECG, and the electronic health record, where the electronic health record lists for these patients their prior history of LVEFs. Can we determine those patients at the highest risk of having a low EF in the future? Now, heart failure is typically grouped in their different classes, but the main classes of interest are heart failure with reduced ejection fraction, and that's when the EF is less than 40%. There's been a plethora of different studies that have outlined a number of medical therapies that affect both mortality and functional status and morbidity, and then heart failure with preserved ejection fraction. And then there is this middle of the road heart with LVEF between 40 and 50%. So the task here is, given some easily obtained data at some point in time t, can you predict when the patient will fall into a relatively high-risk subgroup that have a reduced ejection fraction? Formulation of the problem is as follows. Patient presents, there is a history. So within the electronic medical health, not dealing with the actual images themselves, but the left ventricular ejection fractions that have been reported, typically with an EHR, and electronic health, the ECG that is obtained at some point in time. And the task being to determine within the subsequent year, where the index event is the 12-lead ECG, when the EF will fall below 40%. That is the predictive task. So this is an early fusion task. We have an encoder for the ECG. It's a typical ResNet, which builds your embedding, and then we have some MLP that gives you some final low dimensional embedding, going from 2,500 times 12, 60,000 to 512 numbers. And we have another embedding for the LVEF history, the sequence of numbers that determine the EF in the past. And typically we use some summary statistics here for these. But the point is clear. There is some numbers from the electronic health record, the prior EFs. There is the actual ECG signal. We combine these together, put them through some MLP, and do some of the standard things to get your final prediction. So the data sets that we use here are a few. We have access to data from the Mass General Hospital. There are about 80,000 patients that we use both to develop and test. And these are some of the patient characteristics. And I think these data are always important because they help one appreciate whether the patients used for the development testing of the method are relevant to ones that are seen in clinical practice. And I think that's the case in this setting. We have some additional data from the Brigham Hospital now, which is a separate hospital, albeit in the same healthcare system. And then we have a publicly available data set, MIMIC, which is relatively ubiquitous in all of the literature, especially in the conference literature that has been in the computer science conference literature. So the first question is, how well is this model at differentiating those patients who will have an EF less than 40% in the year after a 12-lead electrocardiogram is obtained? So cut to the chase. If you look at all patients, and this is in the test group with the MGH, and in these two validation sets at the Brigham and with the MIMIC data set, the AUC is quite good, about 92 to 93%. And, oftentimes in the literature, when such models, not for this particular task, but for related tasks are described, it's the AUC that's the be all and the end all for the metric of success, which I think is unfortunate. Now I realize that this is being recorded, right, Danielle? Yes. Okay. So I'm going to really try here. Right. So what I think other important questions are the subgroups of interest that one typically sees. What is the performance like? And one of the good things I think the pile did here is looking at this in different subgroups. So across various cohorts that typify the type of patients that we see in clinic, the performance, at least the discriminatory ability, is relatively preserved. So case in point, you look at those with diabetes, the AUC is still quite high. Those with atherosclerotic heart disease, the AUC is maintained in these subgroups, and even those who are on medications. So it's hard to argue that the method is necessarily just picking up those who are on meds and those who aren't, because in each of these subgroups, it's the same. Moreover, if you look at patients that have a diagnosis of atrial fibrillation, it's the same. There's always a question about how the model works in the setting of having various arrhythmias, AFib being a prominent arrhythmia that's seen in patients with heart failure. And in those that have a diagnosis of atrial fibrillation, as opposed to those who do not, you see all of the discriminatory abilities preserved in both instances. More precisely, although you have a diagnosis of atrial fibrillation, doesn't mean that you are always in atrial fibrillation. So if you look at ECGs that are labeled as having atrial fibrillation, so atrial fibrillation is present within the ECG that's used for the subsequent analysis, the AUC is maintained. And surprising, this is surprising to me as well, even in those ECGs that are paced, it's the same. And even in patients that have relatively preserved EF greater than 40%, it is the same. So these are patients that may be a little bit well, I don't want to say healthier, but have a better prognosis, at least looking at the LVEF, it's preserved. In those that have abnormal electrocardiograms with either indicated by the presence of atrial fibrillation or not, and those that are paced. All of these data are relatively the same. Now, there are two types of patients that this model really looks at. So if you already start out with a low EF, so that your LVEF is less than 40%, and the model predicts that your EF will be below 40% in the subsequent year, it's saying that you won't change. And that's important piece of data. But one could argue that the more interesting application is identifying those who will have a decline in their EF. So those who start out with an EF greater than 40%, who then fall into that. So what happens in this subgroup? So if you look at those patients with an LVF greater than 40, so you just start out with those patients and you try to look at the discriminatory ability in this cohort, you find very similar things in that the AUC somewhat declined. It's about 89%, where it was 92%, but still quite good. And again, relatively preserved over different conditions that are seen clinically and seems to be preserved relative whether you're on the right medications or not. So I think this is a pretty relatively comprehensive analysis in various subgroups showing the discriminatory ability of the model is good. But another sort of soapbox moment is not the AUC is a good metric if it's in some respects, but it is far from a complete description of what's needed to reduce something to practice. The AUC, a good AUC is a necessary condition for a useful model, but far from sufficient. So how do you reduce this to practice? What are the other things that one would like to know? So we've talked about the AUCs, and this is a small plot. It's hard to see this, and these are PRCs also. But here we have sensitivity and specificity plots, and more importantly, we have plots of the positive. I'm sorry, this is I can't recall. This is positive predictive value, and it's negative predictive value. I'm sorry, and positive predictive value. And the results are relatively preserved across the different cohorts. And these are different levels of sensitivity, each of these different lines. So as expected, when the prevalence of the underlying disorder, and it's a function of the prevalence here, and this is the negative predictive value, this is the prevalence, and this is the positive predictive value. With low prevalence, the negative predictive value is high, and with high prevalence, the positive predictive value is high. No secret here, because both the positive and the negative predictive values are functions of the sensitivity, the specificity, and the prevalence. And the specificity is typically a deterministic function of the sensitivity because it's given by the particular cutoff. So this gives you a sense of how well you're expected to do and what number can you most trust. What is the negative predictive value and the positive predictive value as a function of your pretest probability? So if your pretest probability is low, that this patient will have a decline, and we'll talk about that in a minute, then the negative predictive value is well above 95%. And similar statements hold when the pretest probability is high. And you can see that the positive predictive value is modest when the prevalence is low. But if you look at repeated measurements of this, so if you have one ECG and you get one prediction, and it says that this patient is likely to have a decrement in their LVEF in the subsequent year, and a model says that at the next time the ECG is obtained, then those two predictions together are additive in the sense that you can have more confidence when there are two of them, and when there are three or more, you can have even more confidence. So this is the number here of subsequent positive predictions from the model, and then the positive predictive value. So what does all of this mean? Between the AUCs, the sensitivity, specificity, and also the positive predictive values. So we think the model overall has good AUCs maintained across different cohorts, different subgroups with a variety of comorbidities and medical therapies. In patients who have an initial EF of over 40%, the method, which we call pulse HF, can discriminate between those patients who have a subsequent decline in their LVEF. Now, assuming that you have an underlying prevalence across this population of 10% per year, and this number comes from other registries, which and from this you can calculate what fraction of patients per year will have an EF reduced to be less than 40%. And roughly, this has been preserved in several different registries, about 10% per year. So using this as your baseline prevalence, the positive predictive values are modest at best, 45%. It goes up to 60%. if you use repeated positive values, but the negative predictive value is about 97% across all three institutions. So what do you do with this? So if you had reason to believe that a patient was at high risk for an LVEF decline, this is where resources can be allocated. Those are patients that deserve more frequent echocardiography as an assessment. And also there is an opportunity to intervene early in medical therapy, as it has been shown that early interventions with guideline-directed medical therapy can improve outcomes in these patients. All of this information, all of these data use a 12-lead electrocardiogram. So these are determinations that happen when the patient is in contact with their healthcare provider. For example, with their primary care provider or with a cardiologist, where they can get a 12-lead electrocardiogram done. One of the other things that Pyle did is she looked at what happens if you just use a single lead, lead one. My group has been interested in some time being able to make important clinical decisions on patients in an outpatient setting. And what is becoming more and more ubiquitous is the use of devices, either watches or pocket devices that can obtain electrocardiographic information. And most of those devices use lead one. Apple Watch, Fitbit are the ones, even the Cardio Mobile, AliveCore, their earlier device just used lead one. So if you were to do this analysis and use lead one instead of the 12, you get very similar results. I won't go over this in any detail. But if you squint and can remember the slide that I showed you twice before, they're very, very similar. And I think this is encouraging because it raises a prospect that you might be able to use this as a single lead. Now, I should say that we have tried before to do this in using a late fusion approach where we have trained both signals separately, and results in late fusion have been very, very poor relative to those that use an early fusion, where you take the signals, you have your encoders, you put that into some larger network, and you back propagate through everything to be able to learn. So the encoders learn information that is joint between the two signals that one is interested in. And it's case in point here. So in the early fusion, so that was one example of an early fusion with just two particular signals. Now, the advantage here again is that you can learn information that overlaps between the different signals because they all see one another at the time of training. But all of the information you learn is relative to a specific task. So you have some task, some loss for that task, and you back propagate through the model, through the encoders. So while you do learn this cross information here, this information across modality, it is conditioned on the precise specific task. So let's say we forgot about the task and we asked the general question, what are the hidden relationships within the data? What can we learn? So can this information be exploited for a variety of downstream tasks? And you noticed as I was speaking that this GPT-5 came up in the background, right? The GPT-5 is sort of this latest iteration. I think some have referred to it as the Messiah, but or words of that ilk. It's an example of a large, sophisticated model that one can use, a foundation model that one can use in principle to train in an unsupervised fashion without a specific downstream task in mind. And the encodings are very rich, which can be used for unspecified or new tasks that may come up in the future. And this similar idea can be generalized, not only to natural language, but to patient data. So I want to talk a little bit about using these models in the context of digital twins. Now, digital twins have been around for a long time, and you know, if you sort of are designing an airplane or a building or a new car, one makes digital twins. You make some copy of the thing that you're interested in designing in the computer, you modify it, and you can assess the effect of that modification in silico. So you don't have to build something from the, from the very beginning. Again, it's a very expensive endeavor. The difference is with an airplane or a building or a car, you have the laws of physics that you can use. And you can encode these laws of physics in the computer to rationally and reliably test the effect of different perturbations. We don't have that with respect to patients. So the models don't, we don't have the laws of physics, or I should say, it's very challenging, if maybe not possible, to use the laws of physics in and of themselves to dictate what a person will do. I guess there's a philosophical question there, when one is a determinist or otherwise, but leaving those considerations aside. So these are stochastic models. And how and what could they be useful for? So modeling health trajectories. So you could imagine a patient and a healthcare provider. The healthcare provider sees this patient, and they have three different medications that they think might be useful for this patient. Well, they could give drug number one to the patient, have them go home and try it, and then try drug number two or drug number three, and it's clearly an unethical enterprise. But what one would like to do is to replicate that patient's physiology in silico, and then try each of these different drugs, and then generate a trajectory conditioned on the fact that they had this drug, and see where the best outcome was. And that's really the holy grail of digital twin modeling. And there are some efforts along these lines, and I think quite a bit of people working on this, and even and some companies there. But there's some issues here. So if you look at this, and just from the standpoint of cardiovascular disease, we have a population of patients. We want to train some foundation model to generate these trajectories. And so we have some transformer model. We can put the data in, and we can have something that will generate it. So, there's things you can do, but the question is what one should do. The problem with this approach, a few things. The typical method for training these models begin with very large representative data sets, but these data sets, especially in real life instances, and patients with cardiovascular disease, contain a lot of heterogeneity, and we don't really understand what this heterogeneity is. Cancer, case in point, breast cancer has two words that describe it, but there are many subtypes. Some of them we know, some of them we don't know. We have 4 different classes of heart failure, but those are the ones that we can readily describe. There's likely many, many subtypes that we actually don't know. So this inherent heterogeneity makes a training task challenging. What you'd like to do is take these patients, identify the subgroups, and then you can design different generative models for each of the subgroups, and potentially using soft prompting or some other formalism. So one would like to be able to identify important clinical subgroups that could be used for downstream tasks, and then have specific models for each subgroup. And I think that's the case where it would be most useful. So now I'm going to talk about some work in the group that's being done by Nassim Utafoli, which is an exceptionally talented student, computer science graduate student in the group. So this represents the traditional transformer, which of the type that is used in the GPT models. We have some tokens, and this is for a clinical trajectory. So we may have a lab value, we may have a vital signs have taken at a particular time, and different data that are taken each day, sometimes multiple times a day. These are encoded in some way and then decoded, from which we can do next token prediction. So all of the information in the past is used and to generate some embedding, and from this embedding, we can use the next token prediction head to generate the token. So this is standard transformer, standard what's done in generative pre-trained transformers. Same thing done in language, it's just now applied to electronic health record. Now, what we are undertaking is 2 separate things. So we have some data which describes a patient's trajectory in time. This is being encoded, similar to what's done here in the baseline model. And for this encoding, we have a next token prediction head, which predicts the next token. However, we have inserted these special tokens here within the patient's trajectory. Here, lab 1, vital 1, day 1, lab 2, so forth. Lab 1, vital 1, and then we've inserted this H and X. This H is a symbol, is a signal to the model to say, I'm not, right now, I want you to generate an embedding that encodes the distribution of future events. So this H is associated with some specific embedding, and this embedding is given to a histogram head, which generates the distribution of the future. So this task for this model is not only to generate the next token, but throughout the original sequence to generate a distribution of future events. So there's two things that the model gives you: some short-term prediction, what is my next observation conditioned on the past, but also a distribution of what's happening in the future. And so the loss here is a combination of two things. It's a loss of the next token prediction, which is standard in transformer models, but there's also a loss that goes over the distribution over the future, So in training this model, a few things. We want to demonstrate that this formalism, which allows you to generate two different types of information on two different length scales simultaneously at once. Now, for this, we use MIMIC4. We have a development and testing set. It's an 80-20 split. The data set is of moderate size, about 300,000 patients, 500,000 hospitalizations. And a model is trained using causal masking. So we have some portion of the past, we hide the future, and we ask the model to predict it. And the error comes from the difference between the prediction and the truth. So I'm glossing over a lot of the details here on purpose because I want to prevent REM sleep mainly from the listeners, from those who are listening. The loss at a high level is a sum of the autoregressive next token prediction loss plus the histogram generation loss. How well do you do in predicting the distribution? How well do you do in predicting the next token? And there's some hyperparameters there you have to put in to weight the relative contribution, but both of these things are happening simultaneously. So at inference time, what we do is we've trained a model, and then we want to say, well, let's say I have this model, it can generate trajectories for some arbitrary length of time in the future. What's a probability that someone will die in the next 30 days, let's say? So for the model, you can stochastically generate a number of trajectories. In this case, we generate approximately 50. So there's a 50 different future trajectories, all suggested by the model. And then for a given task, we just look at the expectation value over the different trajectories to get the model prediction. So let's say we have the past, we feed it into the model. That's what the model uses. It takes the past and it generates the future predictions as well as these distributions. So we can generate one trajectory, and let's say this trajectory says this patient has an abnormal potassium, has a hospitalization, and then dies. Another trajectory stochastically generated has a different statement. There's some renal dysfunction, hospitalization for congestive heart failure, atrial fibrillation, and then they do pretty well. New York Heart Association class 1, and another trajectory, and so forth. When these trajectories are all generated, the risk of death is here a third for these trajectories because there's one trajectory death appears and it doesn't appear now. This is very simple. These things are generated in autoregressive fashion. So in terms of the prediction, are two things we can look at. First is the prediction of the future distribution and what does that and of these distribution for these H tokens, and then the next token prediction. And our thought is that the future distribution also helps you with the next token prediction and vice versa. So looking at next token prediction, we're looking just at the stream of these predicted signals that conditioned on the past. And we looked at a number of things that we tried to pick some tasks that are clinically interesting for patients with heart failure. So will the creatinine be abnormal? Will the hematocrit be abnormal? There's a probability of a discharge if they've been admitted. In hospital mortality, change in white cells, platelets. We have a long list of things. And 4-cluster in most of the instances perform pretty well and over the baseline. Now, the fact that these numbers are pretty high says that for the mimic data set, that a lot of these are not difficult tasks, right? This needs to be, so this is early work. The results are promising on mimic, but we have another set of data both based for patients both at MGB and the Brigham, which we're running studies on now. But I think the results are promising here. Some things I should point out. So the third-day hospital readmission, about 72.4%. I think Ethos was one of the recent foundation models, has a 73 or 74, I think 74%. So it's on par with that. But this, again, this work is at an early stage. Most of the foundation models that I see in this space do not evaluate on this wide swath of problems. And it is our task or our goal to be able to see how well this can be used in practice. And so these different tasks are an important metric for us. So again, looking at not the token prediction, but let's take a look at solutions. Now, so part of this talk is not only about forecasting the future, but it's about patient phenotyping. And what does it mean to phenotype a patient? And why is phenotyping useful? Patients will have different trajectories. They have different even though they may have the same overall diagnosis. Two patients can have a diagnosis of heart failure with reduced ejection fraction, be treated in very similar ways, but it can have very different outcomes for factors that are very hard to understand. So it is our belief that these embeddings that encode the future will be good ways or will form effective ways to identify new patient phenotypes. And so if you look at these patients and you look at the embeddings associated with these H tokens and you try to cluster them, interestingly, if you just look at it, this is a UMAP, both from a baseline model that doesn't use this approach, where this two-tier approach where you can predict first the future distributions, and the next token prediction, it seems very scattered. But at least in this, there seems to be much more structure in the space associated with these embeddings. In addition, if you use these embeddings to actually ask questions, so you're not training a model, you're just looking at the embeddings, and here I've divided this into 5 clusters, or I say Nassim has divided this into 5 clusters, and the question is, for an embedding, if I want to know whether they're going to have an abnormal creatinine in the future, like in the next 128 tokens, I look at their cluster and I see what is the most likely thing in it. Do most of the patients have in that cluster have an elevated creatinine or not? And that's how I make the assignment as to the prediction. So I'm just doing the assignment based on the clustering. And if you do that, you find that the clustering actually does quite well relative to the baseline. It doesn't use this. So for looking at things like an abnormal creatinine, abnormal renal function, hemoglobin, hematocrit, leukocytes, platelets, mortality, in-hospital mortality. So we think that there is something interesting about these embeddings that will allow us to identify new patient subtypes. So for cluster, this method's a foundation model that generalizes clinical trajectories, which can be used to quantify future risk of adverse events. And because it is a foundation model, it is task agnostic in that you can ask it any question without having some preconceived notion of what it is that one wants to predict. I want to contrast this to the traditional approach. I'm interested in death. I'm going to train a model for death. The foundation model, it generates many outputs. And after the fact, you can ask, looking at the trajectory, what are the most interesting things that happen to this patient? It generates embeddings that encode the distribution of future events, and these embeddings provide information about patient phenotype. Now, I should say we have been interested in this sort of deep phenotyping in an unsupervised fashion for quite some time. And for cluster, this foundation model, I think, shows some promise along those lines. But just to be complete, we have looked at this in other settings. So, and I promise I will stop in another 5 minutes. I have like 50 minutes for this, right then. Yeah. So shut me up if I talk too long. So there's a method called event-based contrastive learning, which we worked on a couple of years ago. So here in this method, it begins with some clinical trajectory, some event that one considers to be important. So heart failure admission. And why do I begin with that? So in a patient's lifespan, you identify some points that you think are more important. So it does require some a priori knowledge, some domain-specific knowledge about what type of events, and you build embeddings around these events. Use these events as anchor points, and you use those anchor points in which to build embeddings. So in this case, every heart failure admission for a patient, I'm viewing as being an important event. I have some data before the admission and after the admission, and I build embeddings. I encode both the data before and the data after. And in event-based contrastive learning, there's a contrastive term that forces these embeddings to be similar to one another. So here, for example, Li, J, and you can tell these are supposed to be close together and those that are far away and otherwise. Now, what happens is that when you do this and you cluster these embeddings, similarly, you get some structure in the embedding space. And I think what's interesting is if you construct Kaplan-Meier curves for survival in each of these embeddings, for each of these clusters, and these clusters are all dictated by the embeddings. Now, one could ask, how do we choose 6 different clusters? We went through many different clusters and did traditionally what people do. They're looking at the elbow and sort of the variance curve to determine where's the knee in that curve. So the point being that there are some objective criteria that are used to determine the number of clusters, and they separate very nicely in terms of their survival. So some clusters are definitely much sicker than others. And if you look at the clinical characteristics of those clusters, it's not completely clear why. It's not as if one cluster is much older than another. So there's information to be learned here. In the future, and this is work that is being early work being pioneered by another student of mine, Taya Bergashami. Taya, forgive me for messing up your name if you're there. Where we are directly focusing on the question of patient phenotyping. So you have a patient, electronic health record, you have their history in the past, in the future. We have encoders that build representations of the prehistory, of the history prior, that to some point in the history and after that point. So this is a training task. So you assume you know the past and the future. This is just for training. And then these embeddings, so these are autoencoders. But then there's an embedding space which you build embeddings for these, and this is just an autoencoder. But then there's a projection head where you take these embeddings and you project them into a phenotyping space. And in this phenotyping space, you cluster them. And you cluster them in a manner that tries to preserve this relationship. So the future and the past are clustered together. So it divides the problem of developing embeddings into both directly an autoencoder for embeddings that use a downstream task, but also phenotyping these patients simultaneously so that you can separate them into clinically distinguishable groups. So that is work in progress. So I'll just end by saying what our long-term goal is, in talking about patient phenotyping is, one size does not fit all. But the problem in the clinical space is knowing how many sizes you have and what the size of each patient is. Ideally, we want to take the in-hospital monitoring environment at home so that the patient, the level of monitoring that they get at a place like the Mass General or the Brigham or the BI or any other sort of quaternary care center is very sophisticated. At home, one does not have such information, but there's a subset of patients that would benefit from this. And can we use signals that are at home, easily acquired with deep learning to get the type of information that one would get in a more sophisticated setting? And just as a case in point, ECG monitor, we want to take that information, bring it to the cloud, do some, what I like to think of as sophisticated ML with that, get some measurements, take these measurements, give this information to healthcare providers that can then provide information back to the patients, help them and their health status will deteriorate. So that's what I wanted to say. I wanted to acknowledge the people who actually do the work. So I talked, there was Taya is here. Naseem is here. Payal Chandak is a former student of mine, is also here, and um, everybody else, as well as some of our collaborators at MGH. Okay, I'm on time.
Perfect. Thank you so much for the talk, Colin. Um, so I'll open it up to the room for questions. Just to start us off, I do have one from the chat from the very beginning of the talk when you were talking about the predicting whether or not someone's ejection fraction is going to be preserved or not. So the question from Devin Watt says might be, oh, do you want to just ask your question?
Yeah, if
He's
that's
here. Yeah,
easier.
great,
Happy
great,
to.
great. Perfect,
Okay.
perfect.
Yeah.
Yeah, thanks.
Thanks. Yeah, very interesting talk. Thanks very much. I was really curious about kind of within early fusion models, especially when you're dealing with a lot of different feature sets, kind of the best way to reduce that dimensionality. Obviously, you could use things like PTA, but then you're assuming linearity. I wanted to get your take in terms of using things like autoencoders, or if there's other strategies that you'd really recommend, especially when you're dealing with different data modalities, and you'd like to have kind of a more constrained feature set. And particularly in the context of like attention-based mechanisms. So, like if I wanted to use like multi-headed attention, obviously I want to try to minimize some redundancy in a larger feature set, particularly if some data modalities have more features than others, which is a common problem.
Yeah, no, I think it's a great question, and I will say that usually in our hands the decision is driven by the boundary constraints. So you have real boundary constraints in terms of the RAM that's available, the time that it takes to run the model, especially with large data inputs. Another wonderful student of mine, Zach Berger, for example, has been working on looking at MRI scans, brain MRI scans, and combining that with other sorts of cardiac information. And the scans are just so large. So he wanted to use some existing encoders and some other models that are used for the brain MRI, but the dimensionality of those animals just made this prohibitive. So then he went to an autoencoder. So how do you choose the size of the autoencoder? Well, like most of the things in this space, it is empiric. So I wish I had some words of wisdom that I could impart here, but I can say in practice, it is really just a matter of trying. And typically one is limited by I can, what other resources I have to bear. I can spend this much time. And what's the maximum size of data? I have this much time and this much memory. And what's the max? Because bigger will typically do better, right? And not always, but typically. And so what's the maximum amount of the dimensionality of the model and these representations that I can use?
Yeah, that's a very fair and frank answer. I appreciate it. Thank you.
Thanks. And sorry.
I had another question that actually loops back to the very beginning of your talk, where you were saying that, the patient is giving information to the physician and the physician is operating on that information. So when you're doing all of these tasks that relate to predicting the future, obviously the interventions that the physician is giving is also going to impact the future. So are you incorporating that in any way?
Yeah.
How do you think about that?
No, it's a great point. So a lot of these, the intended use case for these models are at clear decision points. So you could think about so a lot of the early models with evaluating acute coronary syndromes, patient presents with chest pain and cardiac biomarkers or ECG changes suggestive of an abnormality. And it's that point in which you want to make the decisions. You want to think about there's particular times where the decisions will have the greatest clinical impact. If I cath this person, they might live. If I don't, they will die. And so the use case is what guides a lot of this. Someone comes into the healthcare provider for a routine checkup. Should medications be modified? Should an echocardiogram be ordered? The models in and of themselves, I think with that in mind, are not static things. If one wants to incorporate more information, there's certainly things that one could just take a different structure, whether it's a different sort of transformer or recurrent network or so forth, that'll take the interventions to be able to produce what the next one is. But at least our thinking has been these use point, these times of intervention and what are the information available.
Yeah, I was wondering along the lines too, like you can imagine a really extreme case where you have a disease that has a very high mortality, but also a very effective drug. right? If you gather a bunch of people in your population and train a model on that, even though someone's disease is very strong, their prognosis might look very good because in practice, all the physicians who are operating on these people are going to be giving that drug,
Right, right.
so, or yeah, so I'm wondering about that kind of push and pull.
Yeah, no, I think that's fair. And I think this is why it's a part of the information that the part of the information that the patient provides is what medications they're on at that point in time, right? And then so you can think about the patient in a multimodal aspect is everything that is available within the electronic health record.
Gotcha.
Within I want to say electronic, but within their medical record. That's it. And if you could encode all of that, some of there's redundant information, some of it's not useful, but you won't miss anything.
Gotcha. That makes sense. Great. Any other questions from the audience?
As always, great talk, Colin. One clarifying question about the phenotyping, patient phenotyping, the slide that you had with autoencoders and looking at the history of the patients and trajectory. Are you assuming that the phenotyping, like the after the autoencoder, when you go to the clustering, that the history and the future are the same, are going to be close to each other or exactly the
Right.
same?
So there is a the in during training, there's a cosine similarity term
Yeah.
between the previous and the post. So we're trying to train the encoding for the past to also learn the future. So that's part of the training task.
Mhm.
At inference time, we only have the past, and so we only have those encodings. And the clustering only uses the encodings up until some specified point in time, which you view as the present. Does that answer your question?
Right. I think I meant more in in just the training part. When you do the phenotyping after the autoencoder, do you assume that they need to be close to each other?
Oh,
And
I
the
see. I misunderstood. I thought you were talking about EBCL.
no, no,
No,
no,
the
no,
last
the
thing
line
that I
later.
talked
Right,
about.
right.
Today's,
It's a
today's one.
very almost maybe two slides before.
Yes, yes.
Yeah,
Apologies.
yeah,
Apologies.
no worries.
Yeah. So right. So we have the autoencoder that gives you the embeddings. And then for the phenotyping, there is the past. You project the past into the phenotyping space and you project the future into phenotyping space. And a boundary constraint on the clustering is
Mhm.
that the past and the future have to be in the same cluster.
Same cluster.
They have
Okay.
to be in the same cluster. So they have to be in a similar region of
Mm.
the phenotyping space.
Okay.
So
Great. Thank
that's
you. Yeah.
one boundary because and past and future of different patients have to be separate. So there's a similarity term and a dissimilarity term. That's a function of both the past and the future.
Wonderful. Thank you.
Sorry.
Please.
Great. Any last chance for questions from anybody? I think we've had a couple already. Okay, great.
Oh, I actually had a question. Yeah, it was a really great talk. It was really interesting to see like the mo multimodal and like how you're integrating that at like multiple time points. One thing I was curious about is like I would assume that patients who are, under like more critical conditions or like at higher risk would, have more patient data, right, in their health
Mm,
record
yeah.
and or labs taken. Um, so did you see like that there was higher predictive power for patients that like had more of that information?
It's a great question. How do you normalize for the fact that some patients have more data, especially more inpatient data? And insofar as can you tell whether the model is picking up those that have more data from those that do not? So
Yeah.
in the earlier part of the talk, when in the LVEF prediction, we looked at those patients who had the discriminatory ability of the model, at least in patients had lots of hospitalizations and those that do not. So we tried to account for that in that instance, and that did not make a difference. In a lot of the other work, we've for some of the EBCL work, which I only talked about briefly, we use an ICU cohort where all of the patients pretty much had lots of data. I can't say that we've done a complete enough analysis to say that how this is a function of the amount of data. But what I can say is that we have looked in many of these cases, patients that you would a priori believe to be low risk by clinical features, not necessarily because we haven't looked at in terms of the amount or the number of observations, but certainly those that have few comorbidities and other things that are associated with better outcomes. And we've looked at the performance of the model in those subgroups.
Great, thank you. So we have 1 minute left before 3. So in that time, I'd like to, first of all, thank you very much again, Collin, for giving such a great talk. And to let everybody else know that our next seminar will be on Wednesday, June the 4th, and will be given by Jirish Nadkarni from Mount Sinai. So hope to see you all then. Thank you very much.
Right.
Bye.
Thank you, guys. Bye.
Thanks. Bye.
Thank you.